Summarise, which is the first for 2026. My name is Jane Barnett, and I'm delighted to be introducing not one but two speakers today who will be talking to us about an important topic related to glove use, one that's close to many of our hearts in infection prevention. So the first speaker is going to be Dr. Sarah Browning. She's an infectious disease physician at John Hunter Hospital and clinical director of the Hunter New England Infection Prevention Service. She's completing a PhD at the University of Newcastle with research interests in how multi-drug resistant organisms are transmitted and acquired within acute healthcare settings. Our second speaker is Patricia Knight. She's a clinical nurse consultant in infection prevention at the John Hunter Hospital and John Hunter Children's Hospital in Newcastle, New South Wales, with undergraduate and postgraduate qualifications in nursing. She's got extensive experience in paediatrics, and she's found her passion as an infection preventionist. Patricia has a commitment and interest in educating others, and is motivated to find ways to ensure that infection prevention remains relevant. As a result, she enjoys exploring opportunities for innovation. I'd like to welcome you both very much, and thank you for agreeing to be our Weber Training telecast speakers today on the topic of Gloves Off, the Quality Improvement Project. I'll hand over to you. Thank you.
Thanks, Jane. Thanks for having us here today to share our project with you. We're delighted to be here. So Trish and I will both be presenting on the Gloves Off project today. So we're coming to you from the Hunter New England Local Health District, which is the largest health district in New South Wales. So geographically, we're spread across a large area, over 130,000 square kilometres, and we have a population of approximately 1 million residents within Hunter New England who we provide healthcare to. We have 38 hospitals spread across Hunter New England. That includes one principal referral hospital called John Hunter, and that's where this project was conducted. We also have 4 public acute Group A hospitals. So while this project was conducted out of John Hunter Hospital, it's relevant, I guess, in terms of thinking about expansion of this project, and I will touch on our future plans towards the end of this presentation. So ultimately, this project was born out of a sustainability interest, but it does pair up very well with infection control and our interest in that space. So we know that annually, New South Wales Health produces over 50,000 tonnes of waste. Hunter New England itself sends 75 tonnes of gloves to landfill per year. And a typical ward at John Hunter Hospital, which is a 30-bed unit, uses 30,000 non-sterile gloves per month, or over 360,000 per year. So our quantity of glove use is quite substantial, but not any different to other acute hospitals, I suspect. So the carbon footprint of annual glove use at the John Hunter is equivalent to driving around the perimeter of Australia 68 times. So we conceived this Gloves Off project. It's not an entirely new concept. Many of you would probably be aware of the work that was done at Great Ormond Street a few years beforehand, but discussions around this project being completed at John Hunter Hospital began in 2022. At that time, we had a net zero lead who was employed specifically by the Ministry of Health, Tina Wilkie. So Tina is a speech pathologist, but she was dedicating 1 day a week at that stage to environmental sustainability projects in healthcare. So Tina became essentially the lead for this project, and I'm sure she's sorry that she can't be here today to present with us as well. We brought together a team and started planning what this project would look like. We spent some time engaging stakeholders, and we also managed to receive some funding from the Ministry of Health from their health climate risk and net zero unit, which was helpful for the resources we went on to produce. I guess of relevance, I'm probably preaching to the choir here, but we know that gloves aren't always the best thing from an infection prevention perspective. So we know that gloves don't provide complete protection against hand contamination. And this study showed quite convincingly the way in which glove use can actually be detrimental to compliance with hand hygiene. So they showed that hand hygiene compliance was as low as 41% when gloves were used. And 49% of health workers in this study didn't perform hand hygiene when they were removing their gloves. and 37% of glove use potentially led to cross-contamination when health workers were touching multiple surfaces. We suspect, looking at our own hand hygiene data at John Hunter and across the district, that we were probably seeing similar practices here. So we came together as a group of people interested in both sustainability within healthcare and infection control. We decided that our project aims would be improving hand hygiene compliance. That was really our primary driver here. We really wanted to make sure that infection control was emphasised throughout this entire project. We wanted to improve health worker risk assessments in terms of their confidence and understanding. So how do they actually perform a risk assessment when deciding to use PPE, focusing on gloves here. Thirdly, we wanted to reduce unnecessary use of non-sterile gloves. And by the end of the project, we wanted to design and deliver a quality improvement project, which could then be taken up by other wards and other facilities across Hunter, New England. So we didn't just want to do this once, we wanted to create something. If we could show that it achieved the first three aims and was safe to do so, we wanted to be able to provide resources more broadly across the district so that other people could participate in this project as well. In terms of the outcome data, we had to look at glove purchase numbers. So for that, we used procurement records. We wanted to look at unnecessary glove use and hand hygiene compliance. So we used observational audits for this. We had a customized audit tool, and we were able to use that to look simultaneously at hand hygiene, but also looking at glove use and the appropriateness of glove use. So we altered our approach to hand hygiene auditing during the project. We developed a staff survey, which was electronically delivered via RedCap so that we could look at staff knowledge and attitudes pre and post intervention. We had data on our occupied bed days, and we looked at glove purchase impacts by referring to the literature. So we were able to use carbon footprint, get the carbon footprint from lifestyle assessments. We used the weight of gloves, and the cost came from our local procurement records. We chose 2 pilot wards to do this study. That was partly because we didn't want to take on more than we could actually manage as a small group with the resources that we had. We had nurse unit managers on these 2 busy surgical wards who were really eager to engage. But I guess it's important to keep context in mind, and all of the results that you see have come out of these 2 busy surgical wards where glove use and inappropriate glove use was quite high at baseline. We looked at baseline measures, so pre-education audits, glove procurement data, and did our staff surveys. We then launched into an intervention phase where we had ward champions. Trish will speak much more to that in a moment. Post-education audits and data collection came next. We had an evaluation period, and then we looked at developing this roadmap. So if you look at that across a timeline, you can see that we were split into a pre and post-intervention period. The pre-intervention period starting in July 2022, and that went up until June of 2023, where we collected our baseline data and prepared for our intensive launch. We launched the education over a 2-month period, over July and August 2023. If we'd planned ahead, we may have tried to skip the busy winter period, but this was where it fell, and that's when we did it. And then we moved into a post-intervention and maintenance phase. We had long-term follow-up, which stretched out to March 2024 as well. For the analysis, we used statistical modelling to assess the effect of the intervention on glove use rates. We looked at mean glove use before and after the intervention, and our data was adjusted for occupied bed days to account for busyness. We looked at unnecessary glove use and the impact that this intervention had on that. But we were also looking for signs that we may have caused a safety issue. So looking for moments where gloves should have been used but were missed by health workers, and assessing hand hygiene compliance throughout this period. I'm going to hand over to Trish now to go through the intervention. Thanks, Trish.
Trish, I'm not sure whether your audio is on.
Sorry, I was having difficulty unmuting then.
Okay, no worries.
For the Gloves Off campaign, we reached out to a local graphic designer, and they designed the poster that you can see on this page, which gave staff clear indications of when they did need to wear their gloves and when they weren't required to wear gloves. The ward champions wore the lovely bright green vest, so that, you know, they were out there and were clearly visible to the other members of the team, so they knew who to go to get some information. We designed some badges, and we also created the really big posters, which we displayed at the front of both of the wards. And so, yeah, just gonna... So the pre and post intervention glove usage audit tool. So we used the Australian National Hand Hygiene Initiative audit tool, and we adapted it with the permission of the Clinical Excellence Commission, and they actually gave us some extra things that we could consider with when gloves were needed and when they weren't. So, for example, initially we said that you would still wear gloves if you're having contact with non-intact skin, but the Clinical Excellence Commission came back and said, no, as long as they're doing their hand hygiene, they don't need to wear gloves if they're having contact with intact skin, sorry. We created the glove usage records as moments, so the same as what we do with our hand hygiene moments. We trained our hand hygiene auditors because they were already familiar with the tool, so we really only had to provide them with a little bit of extra information so that they could actually assess the gloves side of stuff, so whether gloves were needed or were they not needed. We provided clear guidance for that glove usage, and as I said, this was all approved by the Clinical Excellence Commission, so New South Wales Health. The staff surveys were created and put onto RedCap, and we use the RedCap program because all of its data stays within Hunter New England's database systems, but also we could actually send the survey to every staff member on the ward. So we got a list of every staff member and it was emailed directly to them. So there was no chance that staff from other wards that weren't participating in the project could respond to the survey. We made sure that it was limited to the wards that was undertaking the project. The responses were anonymous, so they weren't identifiable at all. We asked them questions like, you know, what wards they worked in, what their roles were, asked them some questions about the 5 moments of hand hygiene to get an idea of what their knowledge base was, what their attitudes were. We also looked at what their perceptions were of climate change in the workplace and whether it was something that was important to them. And in the post survey, we looked at getting an assessment on the education, and the reason why we went down that track is we wanted to see what worked really well and what didn't work, so that when we developed the tool for rolling it out to the rest of the district, we knew what worked and what we had to continue to use. Each survey was open for 2 weeks, and 2 reminders were sent to any people that hadn't responded previous to the survey. So the education, so there was formal education that took place every day on the 2 wards. I alternated the wards, so it was done by myself as a representative of the Infection Prevention Service. And we thought that was very important because, you know, it's infection control standing in front of the staff saying you don't have to wear the gloves all the time. So I think that improved the staff's confidence with the project. They did informal education as well, so the team leaders on every shift handover and the nursing unit managers during safety huddles also did education. And you can see here one of our lovely nursing unit managers standing in front of our Gloves Off poster. They purposely did that every day for every safety huddle just to remind the staff that they were doing the project and to remember about Gloves Off. Tina created a newsletter that we sent out to all the staff members as well. And we had some support from the surgical service educators as well. So they were given very detailed education so that if any staff members questioned them, they were able to explain it. So as you can see, that's just a larger shot of our poster that we developed. It was placed near the glove racks throughout every ward. We made sure that the staff were very well aware that the use of gloves or not use of gloves was based on their own risk assessment, and that was important, that nobody judged staff on choice to wear the gloves or not. We discussed with them about medication preparation, so that was one of the main things that came up that staff were concerned about whether they needed to wear gloves when they're preparing medications. And we also did a lot of work on when you should be changing your gloves. It's not unusual to see staff walk down the ward with a pair of gloves on, going from one job to the next. So in any type of healthcare industry, we find that food is the best method of bribery and blackmail to get people to come to education. So we created all of these biscuits and cakes and dangled them in front of the staff's faces and said, come to education and you can have cake. This worked really well. We even managed to get a few doctors to come in and join us as well. And we know how busy they are and that it's difficult for them to walk off the ward sometimes. So we used that. We decided that we wanted to create a little bit of hype around it. So we created the Gloves Off jingle. This goes to the tune of the Beatles' Love Me Do. We also created a rap song as well, and we filmed the original version of the rap song on the wards and involved some of the staff that were working on the wards as well. So this created a lot of excitement and a lot of chatter about the project. It really, got everybody really excited. So the results, oops, sorry. So as you can see on this sheet, when gloves were used prior to the education and when they were used post. So you can see that, for example, Ward H3 in May, were using gloves 53% of the time when they needed them and 40% of the time they weren't actually needed. In the post period, you can see that we reduced the unnecessary glove use down to 33% for Ward H3. We got J3 down to 30% unnecessary glove use. So the combined, outcomes was that we reduced glove use overall by 31% for the two wards, unnecessary glove use, sorry. So this was just a breakdown by staff members. So you can see that, the nursing staff were using them unnecessarily 63%. We got that down to 29%. The doctors were using them 26% of the time. They were using gloves when they weren't needed. We got that down to 7%. Allied health made a significant difference. And personal carers also did some fair improvement as well. This is the glove numbers per month. So you can see that at the commencement of our project in May 2023, we used 78,200 gloves across the two wards. And by the end of the project, we had that down at 47,400. So this is just a quick slide just to show the trend of the glove usage before and after the intervention. So the results, so the glove purchase impact, so we had a decrease of 6.9 gloves per occupied bed day with 1,887 occupied bed days per month, resulting in a reduction of 443 kilos of carbon footprint. And we reduced our waste by 44.8 kilos. And we saved the facility $651 a month. So the results of the unnecessary glove use and hand hygiene compliance. So you can see that our hand hygiene compliance improved. Our unnecessary glove use definitely decreased. And our gloves not used but required was rare and remained relatively stable. And I'll hand back to Sarah now.
Thanks, Trish. So I'll go through the results for the staff survey. I think it's important to note, though, the intervention was delivered on the ward and every attempt was made by the project team to involve all types of health workers in that. So absolutely, we did try and include and target the medical officers, allied health, wards persons, But there are some groups that are really much harder to reach than others. And I wonder if some of the difference in those results that we've just seen is probably a reflection of the difficulties we had in giving consistent education to some of those other groups outside of nursing. So in terms of the staff survey, the number of staff who participated in the pre-intervention and post-intervention surveys was quite different. So we had an initial cohort of 124 staff. I apologise, I've not included the numbers here, but 124 who did the pre-intervention survey, and that actually dropped down to 54 staff who completed the post-intervention survey. So we did have quite a few staff not elect to fill out the secondary survey. What you're seeing on the screen now is showing us the 5 moments for hand hygiene and their knowledge around, we wanted to actually test whether staff knew what the 5 moments for hand hygiene are. And so we had a multiple selection question. And the challenge was for them to pick the correct answers. So we did see a little bit of an improvement, but I think much of the education campaign didn't really focus on the 5 moments specifically, but was more about educating on how to do a risk assessment and then how to make an informed decision as to whether gloves were needed in certain clinical situations or not. And I suspect that's why we've seen a small improvement here, but not a huge change. We wanted to also look at attitudes and knowledge of staff. So we were able to show significant improvements across some of the areas that we examined. In terms of staff being able to identify when not to wear gloves, we saw an improvement in the responses from 22.9% correct to 55 or 56%, which was statistically significant. Staff showed some improved ability in acknowledging that gelling of hands was required before they moved on to a next task, although knowledge around that was already quite good before the intervention. We saw a big increase in the confidence that staff had in terms of how effective alcohol-based hand rubs were at reducing infection risk for patients, but also staff members. So you can see for both of those questions, we had an initial result of 24 or 25%, and that increased substantially after we delivered education. So it's good to see that staff were now feeling confident that alcohol-based hand rubs would keep them and also their patients safe if it was used correctly. We also asked them that as a result of the Gloves Off education campaign, have they changed the way that they wear gloves for clinical practice? And 84% of those respondents in the second survey answered yes. So their knowledge around the 5 moments for hand hygiene still did show a significant improvement from 35% correct responses to 57% correct responses, although I would have liked to see probably further improvements in that than we did, but still a good result. Knowledge relating to glove use remained high across the study. Post-intervention, a greater proportion of staff strongly agreed that alcohol-based hand rub is effective in reducing infections, which was fantastic to see. And so we saw strong agreement in the effectiveness of alcohol-based hand rub for both patient and staff protection. We were really happy with how this project went, but there were still many lessons that we learned. And I think if anyone was to replicate this, we could probably provide some guidance on how we could have done this better. The things that worked well, however, were having a really passionate and enthusiastic team. It was really, particularly Tina Wilkie and her energy. She was the driving force behind this project. And having Tina lead this project, but also having dedicated time was really important, because projects like this do take a lot of time from the project team. And other than Tina, who had 1 day a week, we were all otherwise still balancing our full-time jobs on the side. So that was a challenge, but helped enormously by Tina's dedication to the project. We had strong backing from infection control, as I'm sure you've gathered from Trish and myself being here, and that brought confidence to the wards and the health workers who were engaged in this project. And for this project, we were just looking at 2 wards. So I think we were resourced well enough to be able to bring energy to this project and focus on the staff who work in those 2 wards. On reflection, though, we probably could have had more engagement with medical officers and also our ancillary staff. We did try to include them as much as possible. We looked at rosters across all the types of health workers, and we tried to track down any health worker who would have contact with that ward. But of course, other than nursing staff, most other health workers do transition from ward to ward, and they're not really anchored to one ward specifically. So it's difficult to know who else would have actually been involved in this intervention, who might have just missed the intervention, particularly medical officers. They're in and out all day and spread across the whole hospital. We probably could have designed a stronger study protocol in terms of the analysis plan before we commenced. It's something that we were conscious of, but at the time we were thinking more in terms of quality improvement rather than this being a research project. And it's probably grown into being something bigger than we ever imagined it could be. And having ongoing monitoring strategies. So it would be great to be able to comment on the longer term outcomes of this study. We did go back and collect data to show that there was seemingly a sustained change in staff behaviours, but given the rotation of staff through the wards, particularly our medical officers, I think it would have been great to build in longer term follow-up. So our project was published in the Infection Disease and Health Journal earlier this year. So for anyone with an interest in this area, please take a read. If you are unable to find a copy, I'm happy to pass one on if you reach out to myself or Trish. I wanted to just touch on future directions because the Gloves Off project was just a pilot, which we anticipated at the start we would try and roll out across LHD, the entire LHD. And we have made attempts at doing that, but we also have had recently a group of junior medical officers who led a project called Gowns Down, which Trish and I were also involved in. And this project focused on risk assessing our use of gloves, but also gowns and aprons in the context of patients who had respiratory illnesses. So we noticed a creep of PPE use, particularly throughout the COVID pandemic. And so rather than just focusing our attention on gloves, we wanted to also try and address the issues that we were seeing with unnecessary use of gowns and aprons. This is important, I think, from a sustainability perspective. No doubt has infection control implications as well, but also from a staff comfort and buy-in perspective. I think if we're asking staff to wear PPE, or if staff feel that they need to wear PPE, we have a duty within the infection control space to make sure that they are well informed, able to do these risk assessments, and we're not just wasting time and going through the motions when it's not actually going to provide any additional protection. The Gowns Down project was also quite successful. This was run just on one busy general medical ward. We ran this through the winter period as well, but it did make us pause and think what was our direction for the future. And so off the back of these 2 successful quality improvement projects, we've actually developed a new and much larger project, which is called Risk Assess for PPE Success. And I feel like I'm stealing Trish's thunder here because Trish is now working in a net zero role with the Ministry of Health, and together with another of our colleagues, Kylie Taylor, together they're working on developing this more comprehensive risk assess program and rolling that out across Hunter New England. So we have actually moved away from the Gloves Off branding somewhat over the last probably 6 to 12 months. The biggest barrier to us doing this was the signs that we had on patient doors. So previously, all our transmission-based precaution signage clearly stated that health workers must wear PPE before entering the room. And that was a message that had made its way across all of our transmission-based precautions as a result of COVID. So we no longer had access to signage that just focused on mask and protective eyewear in the context of droplet precautions, for example. And so staff, particularly the younger staff who have never worked in healthcare pre-COVID, really hadn't been taught to perform risk assessments and weren't aware that droplet precautions didn't, strictly speaking, require the use of gowns, gloves and aprons all the time. So we've had to do a bit of a 180 in terms of the education and support that we're providing staff. We use the same graphic designer who helped us in the Gloves Off project. And so we've developed a new suite of resources, including new signage for our patient rooms when we're using transmission-based precautions. And these have been rolled out now across John Hunter, and we're in the process of rolling out this package. So new signage and the education resources across our 38 hospitals in Hunter, New England. And I should mention this is in line with the infection control handbook at a New South Wales level. So everything we've done is in keeping with the advice from New South Wales Health. We've just taken, I guess, that extra step forward in changing the signs that we're using so that these can inform the way that staff perform a risk assessment and use their PPE for patients who are requiring transmission-based precautions. So I should mention our amazing team. All of the people you see on the screen were heavily involved and integral to the Gloves Off project and the success of that project. And most of us are still contributing to the Risk Assess for PPE Success project, which has been quite popular among staff in HNE so far. If you scan this code, you'll be able to access more Gloves Off information and resources if that's of interest. And I'll stop there and say thank you again for having us. Back to you, Jane.
Thank you very much, Sarah and Trish. What an amazing presentation. I think it was even more insightful than I expected. So thank you for your time and commitment to that. It sounded like a really well-run project. And I really think that sustainability and IPC do need to be linked together more strongly because we are often advocating for the use of disposables in so many parts of our advice that it's a really important project that you've done here. I think you anticipated one of my questions I was going to ask about maintaining momentum, but clearly that's going to be through your Risk Assess for PPE Success project. And I almost wonder whether we need to perhaps get you back at the end of that to update the audience on where that goes to. I was interested in the student nurses on one of your slides, Trish. I think, is there work to be done there linking with bodies of education, like universities, where the students come from around PPE use?
Absolutely, and I have reached out to our local university on several occasions, so I'm being invited to come and speak to them about both the Gloves Off and the Risk Assess for PPE Success program so that they can implement that as part of their training with the student nurses.
That's really great. I think that because otherwise they'll come out and into clinical practice with unrealistic expectations. So I think that's really good. What accounts for the post-intervention staff survey drop in numbers, Sarah? Is there was it just that they were exhausted because it was winter?
It could be. I don't know that I have a great answer for that question, other than maybe it is just the loss of momentum over time. I think there was a lot of excitement at the start of this project. And it is hard to reach nursing staff via electronic means in some ways because they're not a group of people who respond readily to emails, in my experience, because they are busy clinicians who are busy doing their work on the floor. So I think it's partly the, the study group. There was probably a lot more excitement and pressure to do that coming from the NUM and the ward champions, and I suspect that died off a little bit towards the end. We also had the challenge of keeping up with ward rotations. So the doctors, we tried to align our intervention period with a period where we would have some consistency of medical officers, but it's really difficult to do that. The JMOs are rotating through at different times compared to our registrars and other more senior registrars, so we had multiple levels of medical officers with different rosters, and so particularly for that group it was really hard to keep track of who's there, and we were trying to send these surveys out specifically to health workers who were actually involved in the intervention and working on the ward during that time. So
Yes,
it's not something we delved into more deeply, but I suspect momentum was the biggest factor there.
Yeah, okay. Well, that's a really great project, and I'd like to thank you both again for your time and effort in talking to our audience about this. If any of the audience who've listened in have any questions for Sarah or Trish, please don't hesitate to use my email, which is jane@webertraining.com, and I'll make sure I pass those on. There's references at the end of the presentations that you can see there. And also Paul has asked me just to mention the future Weber training, or the forthcoming Weber training sessions coming up next month. We're nearly in March already, it's hard to believe. But the one on the 12th of March has got an intriguing title. But it's actually related to the use of bacteriophages in lieu of antibiotics. So those of you with a keen interest in antimicrobial stewardship, please be sure to link into that session. It sounds like a fascinating one. So finally, I just want to acknowledge and thank our patron sponsors for Weber training, and of course Paul Weber himself in Canada for setting all this up. And I look forward to speaking to you all again in a few months' time. Thank you.